Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling another congenital heart defect. Today, it's ventricular septal defects, or a VSD. So if you haven't listened to our Tuesday episode on ASDs, go ahead and rewind, go back to that episode for a primer. This is the second part for congenital heart defects for the week. As always, though, I'm going to kick us off with our practice question. So while reviewing congenital heart defects with a senior nurse in the PICU, they ask you which defects have increased pulmonary blood flow, and you respond by listing which of the following. Select all that apply. Is it A, an atrial septal defect, B, an atrioventricular canal defect, C, a ventricular septal defect, D, aortic stenosis, or E, transposition of the great arteries? So let's start by breaking down the anatomy of what this VSD, ventricular septal defect, is. Remember, on Tuesday's episode, we talked about ASDs and started with a comparison of the heart to a two-story house. We have the atria upstairs, the ventricles downstairs, and we have a wall, both upstairs and downstairs, separating the right from left rooms. So in ASD, we had a problem upstairs. Now with VSDs, ventricular septal defects, the problem is downstairs. That wall separating right from left in the downstairs, the ventricles, has a hole. So normally, blood's going to flow from the body back to the right atria, down to the right ventricle, and off to the lungs to pick up its oxygen. Then back to the left atria, down to the left ventricle, and pumped out to the rest of the body. But if we have a hole in that wall that separates our right from left, so a VSD, that pressure difference between the left and right ventricles, remember, left ventricle is much stronger, so we're going to go left to right, it will cause the oxygen-rich blood to go through our VSD and back into the right ventricle. So instead of blood going from that left ventricle out to the body, boom, let's bring you some oxygen, it's going to go back to the right ventricle and loop to the lungs over and over and over. So just like from Tuesday's episode, this is a left to right shunt. Why are we going left to right? Because the pressure on the left side is higher. Blood is lazy. It goes downhill. So when blood comes back to that left atria and down to the left ventricle, it's going to take the path of least resistance and go left to right across the VSD, that hole between the left and right ventricle, and then it gets into the right ventricle and it just goes back to the lungs, okay? So think back to Tuesday's episode. We are again getting pulmonary overcirculation. Instead of blood going from the left ventricle out to the body, it is looping back to the lungs, causing extra blood to go to the lungs. That leads to tachypnea, retractions, crackles, the right ventricle hypertrophying because it's getting extra blood and working extra hard. Now, clinically, this is more pronounced typically than when the problem is upstairs in between the atria because the ventricles are bigger, so we're getting even more blood out to the lungs. So in our last episode, we saw, that right ventricle hypertrophied. We were having some syncopal episodes. We had a murmur. There were all these signs that we were getting too much blood to the lungs. Now, that is going to be even more pronounced with a VSD to the point where typically around 2 to 8 weeks, infants will start to show signs of heart failure. They are not feeding very well. They are really sweaty, especially when they do feed. They're getting respiratory infections. These kids are burning so many calories just trying to breathe because they're getting so much extra blood to their lungs. So they really struggle to gain weight. Again, they're going to have that murmur. It is typically described as a holosystolic murmur. So we hear it throughout systole, that same situation we saw with an ASD. How loud it is depends on actually how big the defect is. So VSDs can range from being, pretty small to really, really large. But overall, you kind of best hear it down at the lower left sternal border. And unlike with ASDs, where the murmur comes from extra blood going across the pulmonary valve, this murmur comes directly from that defect in the septum. So blood is basically whooshing from left to right across that VSD during systole, and it's causing this sound. Let's actually take a second to listen to that sound so you can hear what does this holosystolic murmur of a VSD sound like. Awesome. All right. Now, that clip is not something that I made. That came from the Wikipedia Commons site, and I'm going to link that resource for you because I think it is just so super helpful to actually hear that before you're hearing it in practice for the first time. One little tip I will give you is listen to everybody. Listen as much as you can, your friends, your families, auscultate as many hearts as possible. Because if you get really good at what does a normal S1, S2 sound like, when you hear this abnormality, this murmur, it's going to jump right out to you. Maybe you won't know exactly what it is, but here's a newsflash. No one's going to diagnose exactly what something is just from a murmur. But if you can pick out like, hey, that doesn't sound normal, you will know to ask for help, get more eyes on it, get further diagnostics. So all that to say, your key takeaway for a VSD, let's review here. The oxygenated blood from that powerful left ventricle is being pushed across a hole in the septum over to the weaker right ventricle and therefore back into the lungs. So that means more volume in the pulmonary circuit, more work for the right side of the heart, and all that respiratory strain. We start to see that heart failure, that crackle, that dyspnea. They're not gaining weight. They're sweaty because we've got too much blood to the lungs. Now, I have seen a lot of VSDs. From working in a pediatric cardiac ICU, this is a common one. So the story I'm going to tell you today is one that I have seen several times. A 2-week-old that was born full term, uncomplicated delivery. They did hear a murmur at the hospital before they sent him home, but it was a faint murmur, and a lot of babies have murmurs. Everything else looked good with him. He was feeding, he was breathing comfortably, maintaining his temp, all the things babies have to do before they're allowed to be discharged. So the family was sent home. The murmur was noted in the baby's chart and follow up with the pediatrician. So babies typically have a 2-day follow-up with the pediatrician and then 2 weeks. So at 2 days, he was still looking good. He was eating. He was down from his birth weight, which is expected at 2 days, and they went back home. They kept doing the newborn thing. Now he comes back at his 2-week follow-up, and he was down even further. At 2 weeks, we want babies back up to birth weight. That's a pretty big deal. So the fact that he was even less than at his 2-day visit was like, oh, this baby's not doing too good, okay? So he was feeding poorly once they started talking to mom. He felt kind of clammy. He was very sweaty. They noticed, they were like, yeah, honestly, he kind of stinks. Like, he's so sweaty and smelly. I'm so worked up every time he tries to eat. The peds re-examined the heart, listened again for that murmur, and it was louder and harsher. He was like, okay, this is going the wrong direction. We're going to go ahead and send you over to the ED. So in the emergency department, they went ahead and got labs, they got his vitals, and they got an echo. So remember, echo is kind of that like ultrasound situation to visualize the heart, and they could see that VSD. All right, significant hole between the ventricles, causing too much blood to go from left to right and recirculate through the lungs, that pulmonary overcirculation. That is what was causing all the baby's signs. He was going into heart failure because extra blood was going to his lungs, okay? That high pressure left ventricle was pushing oxygen-rich blood from the left to the right. That right ventricle was funneling it to the lungs. That made it hard to breathe, hard to eat. That's why he was losing weight and not growing. His heart was just working overtime. Okay. So he was sent from the ED. Once they got that echo, they saw the situation. They went ahead and admitted this baby. And that was where I took care of him as a nurse. I was on the floor and we started doing what we could do to make it easier on his little heart. Ultimately, as I'm sure you can guess, he's going to need surgery. We need to close that hole between his ventricles. What can I do as the nurse first? Make it easier for the heart to do its job. So think heart failure interventions. First, I want to do some diuretics to get that fluid off. We got extra fluid to the lungs. Let's get that fluid down. That's going to help his work of breathing. Next, let's go ahead and do an ACE inhibitor like a nalopril. That's going to reduce afterload, make it easier for the heart to pump blood forward, okay? That's reducing the pressure on that left side, so we're kind of giving that left ventricle a little bit of an advantage. We also went ahead and added digoxin to increase the contractility of the heart, help make it more efficient at its squeezing to squeeze that blood forward, okay? So that kind of got baby stabilized, all right? Over the next 24 hours, he was breathing easier. He wasn't quite so sweaty. I will say this baby never did well feeding. Feeding was still a big challenge. And overall, babies that have any heart failure for any reason, they get tired really quick. They burn calories really fast. So for this baby, because he had lost a good bit of weight and was pretty tiny, we dropped an NG tube and started really high calorie feeds. So that was going to help support weight gain and just make it easier to get him calories without him burning calories, okay? When babies breast or bottle feed, they are burning calories. When we drop an NG tube and we just plop that food into the belly, they're not burning calories, we're just getting it to them. So really got to support that nutrition, get him in a good place, all right? I want to say it was about 2 days before cards came back, did another echo. They started their surgery planning. For him, with the size and location, they were like, it's not going to close on its own. So we need to go to the cath lab and actually close it for him. They did a percutaneous device closure, minimally invasive. They just patched up that hole. Again, if we're thinking about the heart as a house with atria upstairs, ventricles downstairs, and we got walls separating our right from left rooms, we're just putting up drywall. We're patching a hole in that drywall, in that septum, in the middle of the heart, okay? And for him, this procedure went beautifully. Again, this is not uncommon, so this is something we see a lot. One thing I do want to briefly mention, though, is that after a VSD procedure, we are going to implement subacute bacterial endocarditis, so SBE, prophylaxis. So this just means we are giving antibiotics to prevent that bacterial endocarditis. They are high risk for that because of the turbulent blood flow that was going across that defect. So for VSDs, typically it is 6 months post-op that they are on an antibiotic to prevent that bacterial endocarditis. Now, in this particular case, baby stayed with us on the floor for about a week. We were able to pull that NG tube a few days after surgery. He was eating much better. He was not back up to birth weight by the time we discharged him, but he was starting to move in the right direction. He wasn't so sweaty. That murmur was gone once it was patched, and he was able to go home and follow up. So close follow up with cardiology and with his pediatrician, of course. So the big takeaway for you here, if you've got a loud murmur, you got poor feeding, that is not something to brush off, okay? When we have that hole in the heart, whether it's up top between the atria or down below between the ventricles, we are going to have extra blood going to the lungs. We've got that left to right shunt. It is overwhelming the lungs, causing that right side to work extra hard, okay? Which brings us to our practice question. I hope by now, if you've listened to ASD and VSD, both our episodes from this week, I think you're going to get it. But what I want from you is to tell me which of these defects have increased pulmonary blood flow. Okay, is it A, an ASD, B, an AV canal defect, C, a VSD, D, aortic stenosis, Or E, transposition of the great arteries. Select all that apply all the defects that cause increased pulmonary blood flow. What is it? If you said A, B, and C, those first three options, you are absolutely correct. These are our defects that occur when we've got holes between the right side and the left side of our house here. And remember, when that happens, left side has more pressure. We go from high to low pressure, so blood shunts from left to right and therefore sends more blood out to the lungs. Increased pulmonary blood flows. The ASD is when it happens up top between the atria. The VSD is when it happens down below between the ventricles. The AV canal, atrioventricular canal defect, is when it happens both upstairs and downstairs. AV together. And all of these defects cause blood to shunt from left to right and get extra pulmonary flow. D and E, aortic stenosis, TGA, transposition of the great arteries, we do not see increased pulmonary blood flow. So remember your key takeaway, which defects flood those lungs, give them extra blood. Remember, it's when we've got holes between the right and the left. ASD up top, VSD down below, and our AV canal is when we get them both together. Regardless, when we've got that hole between left and right, blood's gonna shunt left to right and send too much traffic out to the pulmonary circuit. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.